Good morning, everyone, and thank you so much for tuning in to another NCLEX review. Today, we are going to dive into Module 8. Module 8 has adult endocrine, it also has oncology and hematology and immunology as well. So, it is a very heavy chapter, but I believe that if we stick to the basics and stick to the important principles you have to understand, that it is definitely doable. So we're going to go ahead and get started. So Module 8 starts on page 246 in your study guides. And so make sure that you are reviewing and reading the entire module so that you understand these specific topics. Everything that you see listed before the module chapter actually starts, you have to read in the chapter and understand before you go and take the NCLEX. When you meet with me, we focus on the very important points, but still, in order for you to increase your chances of success, you should read the entire module. So, endocrine, the beginning of the chapter starts with a basic review of the anatomy. So, let me share the screen with you here. So first up is we're talking about the endocrine system. So the endocrine system is made up of different glands. So you have your hypothalamus and your pineal gland and pituitary gland, which are in your brain. You have your thyroid gland, which is in your neck, your thymus, which is at the top of your chest. You also have an adrenal gland on top of each kidney. You have your pancreas, which is in the center of your abdomen. Females assigned female at birth have ovaries, and assigned male at birth have testes. Also, on the back of the thyroid are four parathyroid glands. So, what is a gland? A gland is a structure that secretes or releases substances. So, a gland is categorized by where it secretes those substances. Okay, so a gland is just a structure that releases substances. It secretes something, okay? And usually what we say is that glands secrete hormones. So also they can secrete enzymes, they can secrete sweat, oil, right? So a gland is categorized by where it secretes things to. So an exocrine gland secretes substances to the outside of the body. And we usually term it as the gland has ducts. Okay. For example, your sweat glands are exocrine glands because they secrete sweat from the inside of the body to the outside of the body, right? On the surface of our skin. An endocrine gland, which is what we're learning about today for endocrine system, they secrete what we call hormones inside the body, and they travel through the bloodstream. And what a hormone does is it's released from one part of the body and it travels to another part of the body and it causes some type of reaction. Okay, so for example, your adrenal glands can release adrenaline and cause the heart to pump faster or to beat faster. So that's an example of the adrenal glands are all the way on top of the kidney. The heart is some distance away from it, but that's the definition of a hormone. It is released from one part of the body and causes activity or reaction in another part of the body. So adrenaline is released from the adrenal glands on top of the kidneys, but then has an effect of increasing the heart rate. Okay, so some functions of the endocrine system to maintain and regulate vital organs, help in the response of stress and injury, growth and development, energy metabolism, reproduction, and also it assists in fluid electrolyte and acid-base balance. So we reviewed the main parts of the endocrine system already. Okay, so that's there for you. And just a brief overview. So the hypothalamus is located at the base of the brain. between the thalamus and the pituitary gland, and it connects the endocrine system to the nervous system. It activates, controls, and integrates the peripheral autonomic nervous system, and also it processes somatic functions like body temperature, sleep, and appetite. So here are a list of hormones released by the hypothalamus, and you're going to see some of these names again, and it's going to click. So corticotropin releasing hormone, gonadotropin releasing hormone, growth hormone inhibiting hormone, growth hormone releasing hormone. So when growth hormone inhibiting hormone is released, it inhibits the release of growth hormone, versus growth hormone releasing hormone will cause the release of growth hormone. Melanocyte inhibiting hormone, prolactin inhibiting hormone, and thyrotropin releasing hormone. So you're going to hear names similar to this, and it's going to form a bridge later on. Next up is the pituitary gland. It's often called the master gland, and it's located at the base of the brain below the hypothalamus, and it is influenced by the hypothalamus. So a lot of people call the pituitary gland, like I just said, the master gland, but it's so funny because the pituitary gland is influenced by the hypothalamus. So really, it's like the hypothalamus is running the show because it influences the pituitary. The pituitary gland promotes the growth of body tissue. It influences water absorption by the kidneys and controls sexual development and function. So some hormones released by the pituitary gland. So the pituitary gland has two main lobes, the anterior pituitary and the posterior pituitary lobes. So anterior adrenocorticotropic hormone, follicle stimulating hormone, which has a lot to do with reproduction and fertility, growth hormone, which does what it says. It helps us to grow and develop from, the bodies of children and adolescents to fully grown adult bodies. Luteinizing hormone, which also deals with fertility and reproduction. Melanocyte stimulating hormone, prolactin, right? So I'm going to switch pictures, but let me just show you something. So when the hypothalamus releases prolactin inhibiting hormone, that will inhibit the pituitary gland from releasing prolactin. You see? So when the hypothalamus releases thyrotropin releasing hormone, that will have an effect on thyroid stimulating hormone. So everything really ties in together. And then the posterior lobe of the pituitary gland releases oxytocin and vasopressin. So these hormones are produced by the hypothalamus but stored and secreted to the blood when needed. So oxytocin, we're going to talk about that a lot when we get to maternity. And vasopressin, we're going to talk about in a little bit. That's also called antidiuretic hormone. A memorizing moment, the pituitary gland makes growth hormone. Okay? So when we take a look at what happens when an individual has growth hormone deficiency or GHD, we can see that these children are the same age, but the child in the green shirt has a normally working pituitary gland, and they have normal levels of growth hormone. So we can see these two children are the same age, but the child with growth hormone deficiency is significantly smaller in height and in form. So just remember, the pituitary gland makes you grow from petite to an adult. So pituitary, petite to adult, because it makes growth hormone. Next up is the adrenal gland. So you have one on top of each kidney. And so the adrenal gland, they regulate sodium and electrolyte balance, affect carb, fat, and protein metabolism, the development and sexual characteristics. They sustain the fight or flight response. So the adrenal glands, so you have one on top of each kidney, and if you were to slice one in half, you would see that it has an inner, which is called the adrenal medulla, and an outer, which is called the adrenal cortex. So I always remember the M in medulla is for middle because the medulla is inside. Um, and so both aspects of the adrenal gland, both of those locations, the cortex and the medulla, really those tissues, they secrete very different hormones. So the adrenal cortex is the outer shell of the adrenal gland, and it synthesizes glucocorticoids, cortisol, which is called the stress hormone, and that's associated with weight gain and water retention. So that's why, having high levels of stress, that causes the release of cortisol, and that really contributes to weight gain. Okay. Also, the adrenal cortex releases cortisone and corticosteroids. So cortex, cortisol, cortisone, corticosteroid, and also mineralocorticoids, which is one example is aldosterone. So these are all steroids. And so one thing to keep in mind is that anytime something ends in "-one" or "-sone", anytime it ends in "-sone" or "-one", it's usually a steroid, okay? So cortisone, corticosteroid, aldosterone, betamethasone, okay? Those are all steroids, okay? And remember, you have to get this memorized, okay? And let me put this slide up for you. So steroids end in "-one" or "-sone, prednisone, hydrocortisone, and all steroids reduce inflammation. And because steroids reduce inflammation, they increase the risk for infection. They also increase white blood cell count. Steroids increase blood sugar. Steroids irritate the stomach lining, so they can lead to stomach ulcers and upset stomach. And also steroids increase the risk for bruising and osteoporosis. So please, please, please memorize that. Okay, very important for you to know. And then now we're going back, the adrenal medulla, which is in the middle, that secretes, it works as part of the sympathetic nervous system, and it produces epinephrine and norepinephrine. So make sure you know the other name for epinephrine is adrenaline, and the other name for norepinephrine is noradrenaline. So this is involved in the fight or flight response mechanism. Next up is your thyroid gland. Your thyroid gland is located in your neck. It wraps around your trachea, and it controls the rate of metabolism and growth. So just memorize that the thyroid gland controls metabolism, and it produces thyroxine, T4, triiodothyronine, T3, and thyroid calcitonin. Okay. Then we have your parathyroid glands, which are located on the back of the thyroid gland. You have 4 of them, and they control calcium and phosphorus metabolism. Okay. Then you have your pancreas. Your pancreas, which is located in your abdominal cavity in the epigastric region, that influences carb metabolism and fat and protein metabolism, and it produces important hormones like insulin and glucagon. Okay, and the ovaries and testes, they're located in the pelvic cavity, and they produce sex hormones. The ovaries produce estrogen and progesterone, the testes produce testosterone, and these help control the development of secondary sexual characteristics that define us as adult men and adult women. So we're going to learn about different imbalances. So these are the different endocrine disorders that I recommend knowing before you go take the NCLEX. So the pituitary gland disorders, When the pituitary gland is not working adequately and it's producing a low level of hormone, specifically growth hormone, we call that hypopituitarism. When it's secreting a high level of growth hormone, we call that hyperpituitarism or acromegaly. Then we have antidiuretic hormone disorders. When it's low, we call that diabetes insipidus. When it's high, we call that syndrome of inappropriate antidiuretic hormone. Next up is the adrenal hormone disorders. When they are low, when that level is low, like low steroids, we call that Addison's disease. When it's high steroids, we call it Cushing's syndrome. Thyroid disorders, when the thyroid is not working enough, we call it hypothyroidism, or overworking, hyperthyroidism. And parathyroidism disorders, we have hypoparathyroidism and hyperparathyroidism. So please, I'm going to give you a few moments, write these down, and make sure you study these by reading the module and also listening to what we're going to talk about in lecture to properly prepare you. So I'll just give you a short couple of moments to write these down. All right, guys, so we're going to get into our first set of disorders, our first pair. So, first up is the pituitary gland disorders. So, individuals with hypopituitarism, they have hyposecretion of pituitary gland hormones, specifically or including growth hormone, thyroid stimulating hormone, follicle stimulating hormone, and luteinizing hormone. So they're going to have issues with growth, okay? And also they're going to have issues with fertility issues. So starting on page 252 at the bottom and then into 253, I have what you need to know in terms of assessment and interventions. So hypopituitarism, they're going to feel very tired and have poor exercise tolerance, low blood pressure, poor cardiac output, obesity, and infertility and sexual dysfunction. The treatment is to replace the hormones that they are low in, and nursing considerations is to provide emotional support for body image and infertility. Okay, so long story short, hypopituitarism, they're going to have issues with growth and with fertility. And so the treatment is to replace the hormones that they are deficient in. Hyperpituitarism, this is called acromegaly. So they have hypersecretion of growth hormone. So they grow to be extremely large. Okay, so they have large hands and feet, thick jaw and tongue, a narrow airway, and organomegaly, which means their organs also grow very large, including their heart, which can lead to cardiomegaly and heart failure. So the treatment for hyperpituitarism includes octreotide, which is sandostatin. Also, they can have surgery if it is because of a tumor, or it's usually due to a tumor um, that is pressing on the pituitary gland, causing the hypersecretion. So if it's because of a tumor, surgery is an option. And always remember, the number one priority for hyperpituitarism will always be airway, because it leads to a thick tongue. So their tongue is thicker, but their airway is smaller. So airway and keeping that airway access is always a priority. So let's look at some pictures. So here's a picture of an individual with hypopituitarism, and it causes obesity. And then once we give them growth hormone, which is what they are low in, we can see that their body normalizes. Okay. And here's an individual with acromegaly. So an individual with acromegaly has excessive amounts of growth hormone, and they grow to be very large. Okay, and so as we can see here in the picture, this individual has a pituitary adenoma. So anytime something ends in OMA, that usually means tumor. Okay, so make sure you know that anytime something ends in OMA, that usually means tumor. So pituitary adenoma is a tumor of the pituitary gland. And what happens is the tumor compresses on the pituitary gland, and it can cause it to release too much. And so in this case, it's releasing too much growth hormone, which is what causes hyperpituitarism, which is acromegaly. So individuals with acromegaly are very large. If you see this individual called, I believe his name was Andre the Giant. So as we can see here, compared to men of a normal size, right? And this man is probably very tall compared to a normal person, but still look at him compared to Andre. So this is what we call acromegaly or hyperpituitarism. And remember, your number one priority for an individual with hyperpituitarism is airway. Okay? So the surgery to remove a pituitary tumor, right? So a pituitary tumor is usually going to be the cause of hyperpituitarism. So there's two approaches, and we're in the study guide at the bottom of 253. There's two approaches to remove a pituitary tumor. They can do craniotomy or they can do transsphenoidal. So craniotomy is opening up the skull and performing brain surgery. Transsphenoidal is basically going through the nose. So transsphenoidal is definitely preferred because it has fewer complications. Craniotomy, you're literally opening the skull and accessing the brain. But as we can see here in this picture, transsphenoidal, you're going through the nose. Really, you're going through the upper gums and through the nose, and then accessing the tumor and removing it. So just remember, transsphenoidal is the preferred approach for this surgery, which is called a hypophysectomy. Okay? So hypophysectomy is a removal of the pituitary tumor. Transsphenoidal approach is preferred because it has fewer complications. But any surgery is going to have potential complications. So if it was craniotomy, there is an increased risk for increased ICP, bleeding, meningitis, and in any surgery or intervention where you're trying to treat hyper, so let's say hyperpituitarism, if it's because of a tumor and you remove the tumor, it can cause hypo. You see what I'm saying? So when something is imbalanced and you go try to balance it, there's always a risk that you bring it in the opposite direction. So if you have a disorder where there's too much of something, so you do a surgery or you give a medication to reduce it, you can reduce it too much and lead to hypopituitarism. Okay? If they're going to do the transsphenoidal approach, which is called the sublabial transsphenoidal surgery, it can lead to cerebrospinal fluid leak. It can lead to infection, diabetes insipidus, and hypopituitarism. So post-operative interventions for hypophysectomy and we're trying to correct hyperpituitarism, right? And so they went in to do surgery. So post-op interventions include monitoring vitals, neurostatus and level of consciousness, elevating the head of the bed, monitoring for increased ICP, avoiding sneezing, coughing, and blowing the nose. Okay, so what does that mean? We do not want to, and write this down, we do not want to increase ICP after hypophysectomy. Okay, and remember, we're trying to bring everything full circle. Hypophysectomy is removing a pituitary tumor. Okay, and so afterwards, we do not want to increase ICP because we know that increased ICP can lead to complications and poor blood flow, okay, of the brain. We learned that in neuro. All right, so post-op interventions, we want to monitor the vital signs because we're looking for Cushing's triad of increased ICP. So remember, the vital signs of increased ICP are the opposite of shock, okay? So let me make this a little smaller. Okay, so what does that mean? So remember, shock vital signs is low blood pressure, high heart rate, high respiratory rate, correct? Let me know in the chat if you agree that the vital signs of shock are low blood pressure, high heart rate, high respiratory rate. So the vital signs of increased ICP are the opposite of that. So that means the vital signs of increased ICP are high blood pressure, low heart rate, and low respiratory rate. So on your exam, you need to be looking if after any type of brain surgery or any type of neurological procedure. So hypophysectomy is considered like a neurological surgical intervention, okay? So after that, you're monitoring the vital signs to see if they have the vital signs of increased ICP, which would be a high blood pressure, low heart rate, low respiratory rate, because that would indicate potential increased ICP, and you would want to communicate with the healthcare provider. You would want to monitor the ICP, which would be 7 to 15. millimeters of mercury, and you want to avoid activities that increase ICP, like sneezing, coughing, straining, blowing the nose. Okay. You want to use ultra soft toothbrushes because oral care can lead to increased ICP as well. And you want to monitor for any bleeding or discharge. So, you want to monitor for post-nasal drip. So if the client is constantly like swallowing, frequent swallowing or frequently clearing their throat, that could mean that they have a post-nasal drip and it could be cerebrospinal fluid. So you want to report that to the healthcare provider immediately. If they have any clear drainage from their nose, do not wipe it away. Check that drainage for glucose because if it has glucose in it, that means that it is cerebrospinal fluid. Okay, so please make sure you study that. All right, let's do some questions on hypopituitary, hyperpituitary, and transphenoidal. Give me a moment. Okay, question 57. A client is to have a transphenoidal hypophysectomy to remove a large invasive pituitary tumor. The nurse should instruct the client that the surgery would be performed through an incision in the, would it be back of the mouth, nose, sinus channel below the right eye, or upper gingival mucosa in the space between the upper gums and lip? So the correct answer for 57 is 4, the upper, very good, the upper gingival mucosa in the space between the upper gums and lips, okay? So let's look at the picture again. And I know it's a little tricky and it's kind of not fair, but that's how most nursing questions are, right? Okay, hold on. So as we can see in this picture here, let me get my pointer tool. Okay, so as we can see here, they're going through the upper gum. So I know it looks like the nose, but they're really going through the upper gum. Okay, and it is in a way going through the nose, but the first access point is the upper gum. Okay. Question 58. To help minimize the risk of postoperative respiratory complications after a hypophysectomy, during preoperative teaching, the nurse should instruct the client how to, what would you choose if this was the NCLEX? Very good. The correct answer for 58 is 3. So let's talk about it. So we want them to be taking deep breaths because we don't want them to get atelectasis post-op, right? So deep breathing is the best choice to help prevent atelectasis. The client should be placed in the semi-Fowler's position or what the doctor has prescribed and taught deep breathing and how to avoid coughing, okay? We don't want we don't want them doing activities like coughing or frequent turning in bed or using a spirometry because those would all increase the ICP and it could disrupt the suture lines um, by altering the surgical incision site. Um, 59, following a transfenoidal hypophysectomy, the nurse should assess the client for what would you choose? Very good. The correct answer for 59 is 1. So, we're looking for, remember, our priorities here are going to be, monitoring the vital signs to see if they have the vital signs of increased ICP, monitoring the ICP, and monitoring for if they're frequently swallowing or frequently clearing their throat, to report that they have a possible post nasal drip or if they have any drainage coming from their nose, especially if it's clear. Do we just want to wipe that drainage away? Very good. Should we educate? Because could it be, is it just like, oh, that's just mucus, or could it be something else more serious? And what could it be? It could be CSF leak, right? And so, how are we going to test that clear drainage? What are we going to test it for? Very good. We're going to test it for glucose because if that clear drainage is positive for glucose, with what's going on with the patient, that's cerebrospinal fluid. And so we would want to report that to the healthcare provider immediately. Okay, next up, we're going to do question 63. To provide oral care for a client recovering from transfenoidal hypophysectomy, the nurse should instruct the client to, what would you choose if this was the NCLEX? Very good. The correct answer is to rinse the mouth with saline solution because performing frequent toothbrushing, cleaning the teeth with an electric toothbrush, flossing the teeth thoroughly, those would all increase ICP. Okay. And then one more question, 64. The nurse teaches the client to report signs and symptoms of which potential complication after hypophysectomy. And remember what we talked about, balance. Very good. So the whole thing is if somebody's getting a hypophysectomy, they already have hyperpituitarism, right? If they're getting a hypophysectomy, they have hyperpituitarism. But whenever something's too high, like a functioning too high, hyper, and we try to bring it down, there's a risk we can bring it too down into hypo. So that's the situation here where they have hyperpituitarism. So we're performing a hypophysectomy to reduce the level of growth hormone in their body, but we can drop it too much, and that would be hypopituitarism. Very, very good. All right, so let's go back. All right, next up, we're going to learn about the antidiuretic hormone disorders. Okay, so we just went over the pituitary disorders, so make sure you go back and study that and just have a basic idea of what we reviewed. Now we're going to move into a new set. So, antidiuretic hormone. So, we're going to learn what is antidiuretic hormone and what happens when it's too low and when it's too high. Okay. So when antidiuretic hormone is too low in the body, that is called diabetes insipidus. So write that down. When antidiuretic hormone is too low in the body, that is called diabetes insipidus. When antidiuretic hormone is too high in the body, we call that SIADH, syndrome of inappropriate antidiuretic hormone. So, what I want you to remember is with diabetes insipidus, so just study these two tables, okay? So, first off, let's learn what is antidiuretic hormone. Antidiuretic hormone, break that word down, okay? Antidiuretic hormone. What is a diuretic? Put it in the chat for me. What is a diuretic? So a diuretic makes you pee, right? Very good. A diuretic makes you pee. So anti-diuretic makes you not pee. So I want you to memorize anti-diuretic hormone makes you not pee. That's what I want you to remember. Very good. So if a diuretic makes you pee, anti-diuretic makes you not pee, anti-diuretic hormone makes you not pee. Okay? So now let's look at the table to talk about the differences. Okay? All right. So, diabetes insipidus is a hyposecretion of antidiuretic hormone. Okay? So that means the person is not releasing enough antidiuretic hormone. Okay? So, I want to ask you something and put the answer in the chat for me. So, if antidiuretic hormone makes you not pee, if you're not releasing enough antidiuretic hormone, that means the patient is going to be peeing a lot. Does that make sense? Let me know in the chat. So if antidiuretic hormone says no, do not pee, right? If they're not releasing enough of that, they're not going to pee. So this is what I meant to say, okay? So antidiuretic hormone makes you not pee. However, if they have diabetes insipidus, they don't make enough antidiuretic hormone. So there's nothing to stop them from peeing. So they pee too much. But this is how you can remember what it is. So we say diabetes insipidus DI, right? Let me know in the chat if you're with me. Diabetes insipidus is DI, right? Put it in the chat if you're with me. Okay, so I want you to think DI stands for diuretic insane. That means when they have DI, diabetes insipidus, it's like they took a crazy diuretic and they are peeing nonstop. So I want you to tell me in the chat if you've got it, if you're with me. Diabetes insipidus is DI. And DI stands for diuretic insane. So diabetes insipidus means they're peeing like crazy. Let me know if that makes sense. All right, one more time. Antidiuretic hormone makes you not pee. Make sure you memorize that. Diabetes insipidus is when ADH is too low. Diabetes insipidus is DI, which stands for diuretic insane. They are peeing like crazy. That means they have increased urine output. So if they are peeing a lot, it's going to drop their blood pressure. Because it drops their blood pressure, it drops their fluid volume. So the amount of fluid in their body drops because they're peeing all their fluid out. Because they've peed all their fluid out, it makes their sodium level high because they're losing all their fluid. Okay? Also, because they're losing all their fluid, their urine is very diluted. Okay? And what we have a word for diluted urine, and it's called low urine specific gravity. So when you're studying this week, you have to memorize it that way. Diabetes insipidus, DI. So close your eyes and repeat with me. Diabetes insipidus, DI. DI stands for diuretic insane. They're peeing like crazy. Because they're peeing a lot, their blood pressure drops. Because they're peeing a lot, their fluid volume drops. They're losing all their fluid, their sodium stays high. They're peeing all of their fluid, the urine is diluted. And what would we call a diluted urine? It has a low urine specific gravity. Okay? So what is the treatment? Because they have low ADH, we give them ADH. This medication is called vasopressin or desmopressin. And it's basically we're giving them ADH because they're low in it. Some nursing considerations, you monitor blood pressure, Monitor sodium levels, you monitor urine output. So with all of these diseases, whatever it messes with, that's what you're monitoring. Does that make sense? So because it drops blood pressure, you monitor the blood pressure to make sure it doesn't drop too low. Because it rises sodium levels, you monitor because when we mess with sodium levels, we can mess with brain function. Okay? And that's why we're also going to monitor level of consciousness. Anytime a disorder messes, write that down, okay? It's right here. Let me put a star. Whenever you think sodium, think neuro because the brain is going to take in and give away water based on sodium levels. So when the sodium level is too high, the brain is going to release water to try to dilute the high sodium in the blood. And that is going to lead to atrophy. The brain will get smaller and shrink in size. We don't want that. Okay, that's going to affect neural function. So, diabetes insipidus, it's going to drop blood pressure, so we monitor it. It's going to increase sodium levels. We're going to monitor that. And whenever we think sodium, we think neuro. So, we're going to monitor level of consciousness because as the sodium level rises to highly abnormal levels, it's going to decrease brain function. We're going to monitor urine output and put them on fall precautions because that drop in blood pressure can lead to dizziness. So there's a safety issue there. All right. Is everyone okay with diabetes insipidus? All right. Okay. So you're going to have this in your recording. So, take a picture of it, make flashcards, and really just keep repeating it to yourself with your eyes closed. After you studied it, keep repeating it to yourself till you're like, I got this. Diabetes insipidus, it's like a diuretic and saying they're peeing too much. It drops their blood pressure, which can make them dizzy. So I'm going to monitor their blood pressure and put them on fall precautions. It drops their fluid volume, which makes their sodium level look higher. And so because of that, when I think sodium, I'm going to think neuro. So I'm monitoring that sodium level, which should be 135 to 145, and I'm monitoring level of consciousness. And I know that it's going to make their urine diluted. And then let's just look at something really quickly. So urine specific gravity. So urine specific gravity, it basically tells you how concentrated is the urine. Okay? So the higher the urine specific gravity, the more concentrated it is. So if we were to look at these cups of urine, we would see that normal urine specific, normal appearance of urine, right? Yellow, a little darker yellow, right? Light yellow, yellow. This is normal. This corresponds with a urine specific gravity that is between 1010 to 1030. Normal urine specific gravity, 1010 to 1030. It's technically 1.010 to 1.030, but who can remember that? 1010 to 1030, it's yellow in color. The higher the number, the more concentrated the urine. So we say the more concentrated the urine, usually the more dehydrated the patient is. Okay? Then the lower the number, the more diluted the urine is. Okay? So somebody with diabetes insipidus, the urine would look like this because it's a diuretic and saying they're peeing like crazy and their urine is very diluted, which corresponds with a urine specific gravity less than 1010. So I could see that being an NCLEX question. So make sure you know urine specific gravity is how concentrated is the urine. The normal urine specific gravity 1010 to 1030. The lower the number, the more diluted. The higher, the more concentrated. Okay? All right. So back to ADH disorders. So then diabetes insipidus is when ADH is too low. But now we have ADH is too high. So I have a trick for you to memorize when it's too high. What if I told you, oh my gosh, guys, I just met the most handsome man of my life. Would you be happy for me? I I just met the most handsome. I'm telling you guys, I'm gonna marry him. He's the man I'm gonna marry. I'm telling you. Would you be happy for me? You'd be so happy for me, right? You'd be like, girl, God bless you. I hope it works out, right? So I would say, girls, guys, I'm so into him. He's the love of my life. I'm so into him. That means I like him a lot, right? It means a lot. So into, too much, a lot. So I want you to think that, I'm sorry, I clicked the wrong button. I want you to think that SIADH stands for so into ADH. I'm so into him. Too much. I love him too much. So that means SIADH is too much ADH. So that means diabetes insipidus is too little. Okay? So into ADH, the syndrome of inappropriate antidiuretic hormone. Remember, antidiuretic hormone makes you not pee. No pee, right? Because it's an antidiuretic, not pee. So somebody with too much antidiuretic, they're not peeing at all. And here's the problem. They're not peeing. So they have a decreased urine output. So that means all of the fluid is staying inside their body. That increases blood pressure. Does that make sense? Let me know in the chat. All right. So into antidiuretic hormone, they have too much ADH. And ADH makes you not pee because it's an antidiuretic. So SIADH, they're not peeing at all. Decreased urine output means all the fluid is staying inside. They're not peeing anything out. They retain fluids. Very good, Miss Daphne. And that increases their blood pressure. Also, because they're not peeing, let me get my star back. Also, because they're not peeing and they have increased fluid volume, the fluid volume in their body is increased. That drowns out or dilutes their sodium. So they have low sodium levels. And still, remember, anytime we're messing with sodium, we're messing with the brain. Okay? Anytime a disorder causes high or low sodium, it has the potential to affect brain function. So that's why we have to monitor for neuro conditions or symptoms. Also, they're not peeing. Their urine is very concentrated. The little bit of pee they do pee is very concentrated. So that means they have a high urine specific gravity. So remember the picture we just saw? Okay, so they would have, so let's write this for you. So diabetes insipidus would be over here. And then SIADH would be over here. Okay, because SIADH, they're not peeing at all. And the little bit they do is going to be have a high urine specific gravity, very concentrated. Okay. So treatment, because they have too much ADH, we're going to put them on fluid restriction because they already have too much fluid in their body. Then we're going to give them diuretics because they have too much antidiuretic hormone. So now we're going to give them diuretics to make them pee. Also, there's a medication called conivaptan, and we can give them hypertonic normal saline to help with their low sodium levels. Okay? Nursing considerations, monitor the blood pressure because it's too high. We don't want them to have a stroke. Monitor the sodium levels. And whenever we're monitoring sodium levels, we also monitor level of consciousness and put them on fall precautions because changes in mental status can increase the risk for falls. It can lead to confusion. Any alterations in sodium levels can lead to neurological problems, confusion, forgetfulness, and monitor their urine output. Monitor how much and the appearance. Okay? So these are your ADH disorders. So let's do some questions. Okay, so we're just doing two questions for ADH disorders, but these are still very good questions. All right, 66. Vasopressin is administered to the client with diabetes insipidus because it. This one you're going to have to think critically, okay? Very, very good. And this is like a difficult question. We didn't even go over this exact verbiage, but this is what I call a learning question, which is in doing the question, you learn something. And basically, you have to understand that diabetes insipidus. So when you're taking the NCLEX, what are you going to think when you see diabetes insipidus? What two letters are you going to think? Diabetes insipidus, you're going to think what? DI. And then what does DI stand for? What does DI stand for? Diuretic insane. So, how much is the patient peeing? Are they peeing a lot like crazy or not at all? They're peeing a lot because it's like they took a crazy diuretic, right? And then so it says vasopressin, which we know vasopressin and desmopressin are other names for antidiuretic hormone, right? So we know diabetes insipidus, they don't have enough because SIADH, they have too much, so into it, right? So diabetes insipidus, they don't have enough ADH. So we're giving them ADH, which is called vasopressin or desmopressin. So let's read the question. Vasopressin is administered to the client with diabetes insipidus because so they're peeing too much. This medication is going to help them keep some of that water in so they're not losing all their fluid volume. Okay, we don't want to decrease their blood pressure. Diabetes insipidus, they're peeing too much. Their blood pressure's already low. It has nothing to do with insulin. It has nothing to do with glucose production or whatever. Okay, um, the correct answer is two. It increases tubular reabsorption of water because diabetes insipidus, they're losing all their water. This medication is going to help keep it in. Okay, everyone okay? Let me know in the chat. All right, 67. Which of the following indicates that the client with diabetes insipidus understands how to manage care? Very good. So you see how they're trying to trick you? They're trying to trick you to make you think that they're talking about the diabetes mellitus with blood sugar, right? But you're not going to get tricked because you're like, diabetes insipidus, that's DI, that's diuretic insane. They're peeing too much because they don't have enough ADH, right? Because SIADH is when they have too much, right? So you're like, I know this. So you see how they're trying to trick you? They don't need a diabetic diet for diabetes insipidus. They don't need dietary restrictions. So you see, and then exhibit serum glucose. So you can use the umbrella rule for this one. The umbrella rule is when three choices are all talking about the same thing, then the correct answer is the one that doesn't fit inside the umbrella. Okay? So these three, diabetic diet, dietary restrictions, serum glucose level, it's all talking about diabetes mellitus. The only one that's not is one. Okay? So very, very good. All right, guys. Let's take a 5-minute break, and when we get back, we're going to move into Addison's versus Cushing's disease. All right, guys. So next up, we have the adrenal gland disorders. So first off, remember at the beginning of class, we talked about the adrenal glands, which are on top of the kidneys. We talked about that you have an adrenal medulla, remember in the middle, medulla middle, and then the adrenal cortex. And we talked about how they release very specific hormones. Okay, here's another view of one adrenal gland. And so the adrenal glands make cortisol, aldosterone, adrenaline, which is norepinephrine, noradrenaline, which is norepinephrine, and just keeping in mind that these are hormones, okay? And these are specifically what we call steroid hormones. So we talked about in our beginning review that steroids reduce inflammation, they increase blood pressure, they increase the risk for infection, they increase white blood cell count, they could lead to GI ulcers and stomach upset, and they increase the risk for bruising and osteoporosis. And remember, this is also all in your study guide, so please make sure you read the entire chapter, okay? So now we're going to talk about the steroid hormone disorders. So first off, we have Addison's disease versus Cushing's. Okay, so Addison's is when your steroid hormones are too low. How can you remember that? It's low, so you have to add steroids. Okay, that's how you can remember. Addison's, and one of the words kind of went off. Let me just fix this, okay? Addison's is low steroids because you have to add steroids to the patient. Cushing's is too much steroids. And you can remember that. I think of too much couch cushion. They've got too much cushion, and also it makes them very large. So just think too much cushion. Cushing's disease, too much steroids, okay? Um, so Addison's, the problem is hyposecretion of the adrenal hormones. So that's what we call adrenal insufficiency. So anytime you see adrenal insufficiency, that means low adrenal hormones, low steroids. So memorization moment, Addison's is low, so you have to add to it. Assessment, everything is low except potassium. You have to memorize that. Addison's is the low one because you have to add to it. But everything is low except potassium. So low blood sugar, low blood pressure, low sodium, high potassium. So why are blood sugar, blood pressure, and sodium low? Because remember what steroids do. So on page 257 in your study guide, steroids increase blood pressure, in blood sugar, increase blood pressure. So if somebody has low steroids, their blood sugar will be low and their blood pressure will be low. Okay? So remember, Addison's is low steroids, also called adrenal insufficiency. Addison's is low because you have to add to it. Everything is low except potassium. Also, they're very weak because of that low blood sugar and low blood pressure, and they have bronze hyperpigmented skin. So the worst case scenario of Addison's disease is called Addisonian crisis, where the patient can die from shock from the low blood pressure, and they can die from the low blood sugar. So the treatment is you have to add steroids to the patient, okay? So we give them steroids and they're going to need it for life. For Addison's, you add steroids for life. And you have to increase the amount of steroids they take during times of physical stress, not emotional stress, not mental stress, but physical stress like infection, trauma, or surgery, because that's what steroids do. Steroids like cortisol are released when we are under stress, and they increase blood sugar so we have more energy to deal with that stress. And so because somebody with Addison's disease, they don't have that same capability, we have to increase their steroids during times of physical stress for them, and that will be the healthcare provider to determine the dosage. Okay? So on page 259 in your study guide, it also talks about this. It's all right there for you. And then make sure you review Addisonian crisis on 260. So for Addisonian crisis, remember they can die. So the treatment interventions, we're going to give them steroids. For the low blood pressure, we're going to give IV fluids. And we can give dextrose for the low blood sugar. Okay? Is everyone okay with Addison's disease? And here is a picture of that bronze hyperpigmented skin. Okay? And Clex tip, it's best to take steroids in the morning to avoid disturbing sleep patterns like cortisol, which is the stress hormone that we've been talking about. It's highest in the morning, or it should be highest in the morning. So we want to mimic the body's natural circadian rhythm, the natural rhythm to the body. So it's best to take steroids in the morning and take steroids with food to avoid upset stomach, because remember, steroids irritate the GI lining. All right, next up is Cushing's disease. So the problem is hypercortisolism. It's a hypersecretion of those adrenal hormones. So whereas Addison's, it was low, you had to add to it. Cushing's, they have too much. So memorization moment for Cushing's, think too much couch cushion, too much steroids. Also with Cushing's, they become very large and obese. So that's how you can remember like too much cushion, too much. Assessment, everything is high except potassium. So high blood sugar, high blood pressure, high sodium, low potassium. So the few questions that I've seen on Addison's and Cushing's, they usually want to see if you can remember the potassium. So just remember the potassium is opposite of the disease, okay? Addison's is too low steroids, but the potassium is too high. Cushing's is too much steroids, but the potassium is too low. Also, Cushing's, they're going to have truncal obesity and thin extremities. So that means the trunk or the center of their body will be very big and round, but their extremities are very thin. So they're going to have thin arms and legs. Also, they're going to have a moon face, which is a very round face, and a buffalo hump, which is a fat pad. Also, hirsutism, which is female, when a female has excessive facial hair. You can see she has like a little bit of a mustache and hair on the chin. Also, they're going to have striae, which are stretch marks, and a pendulous abdomen. So here we see the stretch marks and the pendulous abdomen. Their abdomen hangs over the top of their thighs. Okay, and they bruise easily and are at increased risk for osteoporosis because Cushing's is too much steroids, and we learned that steroids increase the risk for bruising and osteoporosis. Okay, so the treatment, and I don't know why this keeps moving. One moment. The treatment for Cushing's disease is a high protein diet because the excess of steroids can lead to protein wasting, potassium sparing diuretics, because we want to help with fluid overload, but we don't want to drop their potassium. Surgery, if the Cushing's disease is because of a tumor or something compressing on the adrenal glands, and meteropone. Um, so, what is important to know for these disorders is pretty much the assessment. Addison's, everything is low except potassium. Cushing's, everything is high except potassium. And this is all in your book, okay? Everything is in your book. All right, let's do some questions. Okay, number 68. The nurse is instructing a young adult with Addison's disease how to adjust the dose of glucocorticoids. The nurse should explain that the client may need an increased dosage of glucocorticoids in which of the following situations? So let's go back to the study guide because nobody got it right. So when did it say to increase? You must increase the steroids during times of physical stress. So what are the examples here? Infection, trauma, surgery, physical stress. So now let's go back to the question. So is completing the spring semester of school, is that physical stress or more mental stress? So choice one is wrong because that's not physical stress. Okay. Gaining 4 pounds, I know that can seem physical, but 4 pounds is not like gaining 40 pounds, right? So I wouldn't consider that physical stress. Becoming engaged, that's more like mental stress, right? So in the study guide, it says you're going to have to increase them during times of physical stress like infection, trauma, or surgery. Is a root canal surgery? Yes, it is. So the correct answer is four. Okay. So you can expect to see something like that on the NCLEX where it just wants to know, do you know that Addison's is when it's too low and that you need to add steroids and that the dose of steroids will need to be increased during times of physical stress. And there's three qualifications for that: infection, trauma, or surgery. All right, let's go to the next question. We're going to do 69. Which of the following is the priority for a client in Addisonian crisis? So we're on question 69. So there's a key word here: priority. And so Addisonian crisis, can they die from this? Okay, what are the two reasons they can die from Addisonian crisis? Low blood pressure, low blood sugar, right? And that low blood pressure can lead to what? Shock, right? And so what is the priority here? So what is the answer? There we go. Because some people put relieving anxiety, and I'm like, that's not the priority here. Because Addisonian crisis, are the steroids too low or too high with Addison's? It's too low. And so, what do we have to give them? If they're in Addisonian crisis, they can die from the low blood pressure and low blood sugar. So, because they have low steroids in Addisonian crisis, what are we going to give them? We're going to give them steroids. Very good, because that's the main problem. For the low blood pressure, what are we going to give them? Very good. So for low steroids, we're going to give steroids. Okay. For low blood pressure, we're going to give fluids. For low blood sugar, we're going to give dextrose. Okay. All right, let's do some questions on Cushing's. Okay. A client reports that she has gained weight and her face and body are rounder, while her legs and arms have become thinner. A tentative diagnosis of Cushing's disease is made. The nurse should further assess the client for question 87. Very good. The correct answer is 3, bruised areas on the skin. So this one you have to use process of elimination. So remember, Cushing's, the steroids are too high. So it causes high blood pressure, not low blood pressure. Muscle hypertrophy, no, the muscles aren't bigger in the extremities. The extremities are thinner. And then decreased body hair, no, it would be increased body hair, the hirsutism. All right. Then we're going to do question 89. The nurse should monitor the client with Cushing's disease for which of the following? Very good. You've got it. Very good. Because you're going to remember that Cushing's disease, everything is high except the potassium. Addison's, everything is low except the potassium. Very, very good. All right. So now we're going to move on to thyroid gland disorders. which starts on page 263 of your study guide. So I know I keep repeating myself, but please make sure you read the entire module. So remember, your thyroid gland wraps around your trachea, and just memorize that the thyroid gland regulates metabolism. Okay, and so there's two lab levels that I want you to understand what they mean. First off is T4, and then second is TSH. So I want you to memorize and write this down, that T4 is the truth. I want you to write that T4 is the truth. And then I want you to write TSH, and I want you to underline SH, and I want you to put so hypocritical. T4 is the truth, and TSH is so hypocritical. Because when T4 is the truth, right? When T4 is low, it means hypothyroidism. When T4 is high, it means hyperthyroidism. So that level, it tells you the truth. If it's low, it means low function. If it's high, it means high function. But TSH is so hypocritical because when you have low TSH level, it actually means hyperthyroidism. When you have high TSH level, it means hypothyroidism. So T4 is the truth. When it's low, hypo. When it's high, hyper. TSH is hypocritical. When it's low, it means hyperthyroidism. When it's high, hypothyroidism. All right. Another word I want you to know is goiter. Goiter is an enlarging of the thyroid gland, and it could be due to both hypo and hyperthyroidism. So, your thyroid hormone disorders. For hypo, I want you to remember that everything is slow and low. Okay? So hyperthyroidism, the problem is a hyposecretion of thyroid hormones, and it's very common in the elderly because as we get older, our thyroid function decreases naturally. That's why as we get older, our metabolism decreases naturally. All right? So the assessment of hypothyroidism, everything is slow and low. Bradycardia, weight gain, constipation, heavy periods, cold intolerance, lethargy, weakness, depression, fatigue, forgetfulness, dry skin, dry hair, hair loss, and myxedema, which means puffy eyes. So just remember, for hypothyroidism, if they're slow, low, cold, depressed, constipated, they're getting bigger, gaining weight, right? The worst case scenario of hypothyroidism is myxedema coma. And I want you to underline the coma because it literally can lead to a coma, okay? So the treatment for hypothyroidism is to give levothyroxine. So for hypo, you give levo. All right? Hyperthyroidism. The problem is a hypersecretion of thyroid hormones, and there's two other words for it, thyrotoxicosis and Graves' disease. With hyperthyroidism, everything is too fast. Tachycardia, palpitations, hypertension, weight loss, diarrhea, light periods, heat intolerance, irritability, they get angry quickly, mood swings, soft skin and smooth hair, dysrhythmias, and something called exophthalmos where their eyes bulge out. It's called Graves' ophthalmy. Okay, ophthalmopathy. Okay, so the treatment for hyperthyroidism is anti-thyroid medications like methimazole, propylthiouracil, which is also called PTU, and possible thyroidectomy. The worst case of hyperthyroidism would be a thyroid storm. Okay, so if a patient has Graves' ophthalmopathy, um, the eye care is to wear an eye patch at night to protect from corneal abrasion, artificial eye drops to keep the eyes moist, and to wear sunglasses in the day. Okay, so everything is there for you in the study guide. All right. The last group of disorders we're going to learn about, there's just two more groups really quickly, but the last groups, we're going to talk about the parathyroid glands, which are on the back of the thyroid. So parathyroid glands regulate calcium levels. So they deal with parathyroid hormone. So when they have low parathyroid levels, it causes hypoparathyroidism, which is going to lead to low calcium levels. High parathyroid hormone levels are going to lead to hyperparathyroidism, which causes high calcium levels. Okay? So that's what I want you to know for the NCLEX about that the parathyroid disorders, they just affect the calcium levels. And then because we reviewed electrolyte levels early on, you will know what low calcium causes, right? And what high calcium causes. We know that low calcium levels cause tetany, and we know that high calcium levels cause mold-grown kidney stones, okay? And that was module 2 if you need to review that in your study guide. So removal of the thyroid gland or parathyroid gland can lead to hypocalcemia, which can manifest as tetany. Okay, so for parathyroid disorders, just know that it affects the calcium levels, and that's also in your study guide. The last group of disorders we're going to talk about is diabetes mellitus. So for homework, because we've talked about diabetes before, just review it in your study guide, okay? And it starts on page 267 in your study guide, but it's nothing that you haven't heard about diabetes. Diabetes type 1, they need insulin for life. Type 2, they have hyperglycemia. It can usually be fixed with diet and exercise. If that doesn't work, they try metformin. And if that doesn't work, they try the newer drugs. Hold on, I have a typo, excuse me. The newer drugs, tirzepatide, which is Mounjaro, and semaglutide, which is Ozempic. And just keep in mind that you have to monitor the A1C, the hemoglobin A1C levels of your diabetic patients every 2 to 3 months. And that is going to help navigate their plan of care. Normal hemoglobin A1C is 4 to 6%. So if it's greater than 6, we need to modify the plan of care to help better control their blood sugars, because if we're not controlling their blood sugars, it can lead to, it damages the retina, which is retinopathy, can damage the nerves, which is neuropathy, and it can damage the kidneys as well and lead to kidney failure. It also puts a lot of stress on the heart. All right, everyone. So that is endocrine. That is endocrine. So that's it for today. Go ahead and review this recording. Well, first off, read Module 8, all of endocrine. Then review this recording, review your notes, use your own question banks to do questions on endocrine. I know that you guys are meeting up for the study group, so use the study group to read together. Use the study group to review the recording and pause and take notes together. And use the study guide to do questions together. All right? So if you're interested in joining the study group and you have not, please send me a text message, and then I will help you to get connected with the group leader. Okay? So somebody just put a message that the test is changing in April. It is going to be changing. However, I've already started reviewing the test plan, and nothing has changed too drastically. So don't concern yourself with that, because guess what? Diabetes is still diabetes, no matter how they ask you, right? So I've taken that into account, and I'm still going to prepare you properly and adequately. So again, read all of Endocrine in Module 8 chapter, review this recording, Review your notes and use your question banks to do at least 100 questions on endocrine. All right, guys. Thank you so much. God bless you, and I will see you next week. Thank you. Thank you. Keep up the great work. You are going to pass. You are going to make it. God bless you, and thank you.